Hello and welcome to the Pinpoint lecture in the Psychosis series. This is Dr. Nicholas Hatcher, and in this presentation we will explore the diagnosis and differential diagnosis of psychosis. Here is a reminder of where we are in the series. Now that we have an idea of what the presentation of psychosis entails, we are now turning our attention to specific underlying causes to consider, as this will ultimately guide management and prognosis. In any new onset psychosis, we must first consider any secondary cause of psychosis. This is an important step because correction of an underlying secondary cause will result in a reduction or elimination of psychotic symptoms. Misdiagnosis may contribute to inappropriate management and potential consequences in terms of morbidity and mortality. Delirium is an acute transient disturbance in mental functioning characterized by inattentiveness and fluctuating levels of consciousness. Delirium may present with hallucinations, and commonly these hallucinations are visual or tactile in nature, as opposed to auditory. There are several causes of delirium, and I've listed them for you here using a mnemonic. Several endocrine conditions may be associated with psychosis. Some of these include adrenocorticotropic hormone-producing lung carcinomas, exogenous steroid use, pituitary adenoma or adrenal carcinoma with Cushing's disease, or steroid-producing tumors. Approximately 57% of individuals with Cushing's disease present with concurrent psychiatric illness. Depression is the most common among these. Psychosis is more common in Cushing's disease due to adrenal carcinoma, with approximately 8% of all individuals with Cushing's disease presenting with psychosis. Some characteristic features that may increase the suspicion for an underlying endocrinopathy, particularly Cushing's syndrome, include bruising, glucose intolerance, hyperlipidemia, hypertension, moon phases, buffalo hump, and truncal obesity. The workup would include a CT or MRI of the brain, chest imaging, an A1C, lipid panel, and AM cortisol level. Reducing serum cortisol levels corresponds with amelioration of symptoms. This comes with the correction of the underlying cause and consideration of steroid titration versus taper. Psychosis with thyroid disease is rare, but primarily presents as an affective psychosis, where psychosis corresponds with clinical depression or mania. This often occurs as thyroid levels return to baseline. The etiology may be primary or secondary. Keep in mind, overcorrection of T4 with replacement therapy may induce psychosis as well. Suspicion for a thyroid disease is increased with a concurrent syndromic overdrive with hyperthyroidism or underdrive with hypothyroidism. Possible mechanisms explaining this connection between thyroid hormone and psychosis include the possibility that thyroid hormone interferes with serotonin, gamma-aminobutyric acid or GABA, dopamine, and second messenger systems such as adenyl cyclase and phospholipase C systems. There are some special considerations for treatment. Euthyroid is achieved with 4 to 6 weeks of carbimazole, but 131I is the treatment of choice, followed by T4 replacement. Haloperidol has been used without significant side effects, but some studies report increased dystonia and induction of thyroid storm. Lithium may be continued during 131I treatment. It can be helpful by prolonging intrathyroidal 131I retention. Hyper or hypoglycemia may present with psychotic symptoms. Key characteristics here are an abnormal glucose metabolism, blurry vision, and fatigue. The workup would include a fasting blood glucose, A1C, complete metabolic panel, and urinalysis. Management includes the correction of the blood glucose abnormality. Niacin or B3 deficiency may be suspected in the case where delusions and hallucinations are occurring in the context of alcohol use or eating disorder. Workup includes evaluation for an underlying eating disorder and alcohol use, and vitamin B complex testing. Thiamine or B1 deficiency may be suspected in the context of confabulation, history of alcohol use, Korsakoff psychosis, older age, and Wernicke encephalopathy. Workup includes a complete blood count, serum folate, and B1 testing. Management considerations include thiamine replacement. After just mentioning 2 places where alcohol can be a problem, let's spend a moment differentiating between alcoholic hallucinosis versus delirium tremens. Alcoholic hallucinosis is a benign and transient appearance of auditory, visual, or tactile hallucinations. The onset typically occurs within the first 24 hours after the last drink. These hallucinations are more commonly auditory or perceptual, such as seeing spots on the walls, bugs, or shadows. Delirium tremens, or DTs, on the other hand, is alcoholic hallucinosis plus autonomic instability. And by that, I mean the addition of hypertension, tachycardia, hyperthermia, nausea, and vomiting. The onset here is typically 24 to 72 hours after the last drink. The peak is around the 4th day of cessation and can last up to 2 weeks. As opposed to alcoholic hallucinosis, delirium tremens is a medical emergency. Benzodiazepines with a longer half-life are the drug of choice. B12 deficiency is another consideration. This may be suspected if psychotic symptoms occur in late childhood or early adolescence. In older adults, it presents with ataxia, glossitis, cogwheel rigidity, abdominal symptoms, persecutory delusions, and hallucinations. The workup for this includes a complete blood count, Helicobacter pylori testing, intrinsic factor antibody testing, a serum folate, and vitamin B12 level. Management considerations include replacing B complex with the addition of niacin. Space-occupying lesions, including brain tumors and other benign or space-occupying lesions, may be suspected in the context of headache, seizures, unilateral neurologic signs, and visual hallucinations. The workup would include a CT or MRI of the head and brain. In dementia or Alzheimer's disease, there is prominent short-term memory loss, aggression, agitation, and paranoia. Psychosis occurs in 16 to 23% of patients. Delusions may be mistaken for misperceptions because of cognitive changes. Here, the workup would include a mental status examination, a mini-mental status examination, MoCA screening, or the clock drawing test. If an antipsychotic is warranted, pimavanserin is showing promising results in this particular population. Epilepsy may be suspected as a cause in the context of déjà vu, dissociation, and visual hallucinations. Psychosis primarily occurs with temporal lobe epilepsy and occurs in 7 to 11% of patients. The workup would include an electroencephalogram. In Huntington disease, schizophrenia-like symptoms may occur before cognitive or extrapyramidal changes. Extrapyramidal changes include chorea, which is a Greek word for dancing, and describes involuntary, irregular, and unpredictable muscle movements. The workup here would include a CT or MRI as well as genetic testing. Parkinson's disease presents with a rigid gait, slow movements, stiffness, and tremor. Delusions and hallucinations are common in the later stages, and is typically associated with Lewy body dementia that we will discuss in the following slide. The diagnosis for Parkinson's disease is clinical, and the management includes levodopa-carbidopa, among other things, and pimavanserin again can be considered for psychotic symptoms. What's difficult here is the balance of dopamine. Overwhelmingly, the issue with Parkinson's disease is a lack of dopamine, and treatment aims to increase levels of dopamine. However, with psychosis, there is an elevation of dopamine, which antipsychotics block. Finding this balance can be a clinical challenge. Lewy body dementia is characterized by executive dysfunction, fluctuating awareness, Parkinsonian motor symptoms, and visual hallucinations. The diagnosis is clinical, and on autopsy, one will find Lewy bodies. Antipsychotic use in this case may cause sudden death or worsen movement and should be avoided. Wilson's disease is suspected in the context of abdominal swelling, delusions, jaundice, Kayser-Fleischer rings, tremor, vomiting, and psychosis. The workup would include a serum ceruloplasmin, total blood copper level, with a follow-up 24-hour urine copper test with or without a liver biopsy for copper storage levels. Encephalitis presents with bizarre behaviors, fever, chills, rigidity, decreased sensorium, headache, and hyponatremia. The workup includes antibody testing, electrolytes, lumbar puncture, and MRI of the head and brain. Human immunodeficiency virus, or HIV, is characterized by cachexia, cognitive changes, and delusions. Workup includes a CT of the head, rapid HIV test, CD4 count, and viral load. For management considerations, the psychosis here may be HIV-related or HIV treatment-related. In neurosyphilis, one may appreciate an abnormal gait, cognitive deficits, headache, incontinence, seizures, and visual disturbances. These patients may present primarily with neuropsychiatric symptoms, especially psychosis and mood swings. The workup includes a CT or MRI of the head and brain, lumbar puncture, and treponemal antibody testing. Multiple sclerosis may present with diplopia, ataxia, neuropathy, bowel and bladder dysfunction, and tinnitus. Psychosis may be a presenting symptom. Positive symptoms with persecutory delusions are the most common, and there's a relative absence of negative symptoms. Workup includes an MRI of the brain and spinal cord, lumbar puncture, and electromyelogram. For management considerations, any psychosis presenting in MS may be secondary to demyelination, immunologic factors, or exacerbated by medications, for instance, high-dose steroids. Systemic lupus erythematosus is a multi-system disease that has several characteristics. I provided a mnemonic here that incorporates the diagnostic criteria of lupus. Psychosis occurs in about 12% of patients, and the workup includes an ANA, anti-smooth muscle, and anti-dsDNA. It's important to differentiate SLE, delirium, steroids, and medications as the cause of psychosis. An ovarian teratoma is characterized by altered consciousness, cognitive deficits, pelvic pain, psychosis, and seizures. The workup includes an abdominal CT or ultrasonography. Anti-N-methyldeaspartate receptor encephalitis may be associated with teratomas. Paraneoplastic limbic encephalitis is characterized by neuropsychiatric symptoms, peripheral neuropathy, and personality changes. The workup includes a CT or MRI of the head and brain, lumbar puncture, electroencephalogram, anti-HU antibody testing, and it may be necessary to consider carcinoembryonic antigen 125 testing. 80% of these cases are associated with small cell lung cancer, and it's also important to note that Lambert-Eaton myasthenic syndrome may occur. Drug intoxication or withdrawal typically presents with acute onset, tachycardia, hypertension, agitation, altered mental status, delusions, and visual hallucinations. Some implicated substances include alcohol, benzodiazepines, barbiturates, cannabis, bath salts, ketamine, cocaine, meth, and hallucinogens such as psilocybin and ecstasy. Workup includes history and toxicology. Medication adverse effect, on the other hand, typically presents with a more gradual onset in the setting of antiarrhythmics, anticholinergics, antihistamines, antituberculars, antimalarials, corticosteroids, dextromethorphan, dopamine agonists such as L-Dopa, St. John's wort, thyroid hormone, antibiotics, particularly ciprofloxacin, and antiarrhythmics such as digitalis. The workup here includes taking a medication history. For downloadable content such as written notes, PowerPoint slides, and more related to this lecture series, please visit my website using the link below. You can also support my goal of continuing to provide new content through Patreon, where becoming a patron will provide you with access to downloadable content as I create new content. Thank you for your support. Here are my references for this presentation. Thank you for listening.